And so we have from the California Office of AIDS, Mr. Matt Willis, who is going to guide us through some of the efforts that California has been doing. And again, when we talked about, when we were introducing the Institute earlier, we wanted to let you know that this was in line with the National HIV/AIDS Strategy and also the Ending the HIV Epidemic in the U.S. initiatives. And so Matt is here to tell us a little bit more about what's happening on that level from the state. So please welcome Matt Willis.
Thank you so much for that introduction, Patrick. I am so happy to be here today to talk about some structural interventions that are currently happening within our Ending the Epidemic counties, specifically our prevention-funded Ending the Epidemic counties. Does my slide look okay on the screen? I just want to check before I move forward.
Perfect.
Great. Okay, so before I get started, I just wanted to tell you all a little bit more about myself. I definitely see some familiar names on the call today, so I'm happy to see you all. My name is Matt Willis. My pronouns are he, him. I am the chief of the local capacity building and program development unit, which is within the prevention branch of the Office of AIDS. I'm also one of the state co-chairs on the California Planning Group. Today, I'm actually presenting on behalf of Kevin Sitter, who is the Ending the Epidemics project manager, also with CDPH Office of AIDS. So today, I'm going to highlight some things and just kind of reiterate some points that have been made and just kind of talk a little bit more about structural interventions. Some of these structural interventions you may be already doing. I'm going to talk about the value of including priority populations in the planning and development of structural interventions. So again, the idea of nothing about us without us, and really making sure to get folks engaged in the planning of structural interventions from the jump. That way, we're working with folks side by side from the beginning. We're not bringing people in, unintentionally as an afterthought or after something has already been developed. And then lastly, I'll highlight the collaborative work that is being done to expand the impact of structural interventions. Okay, so we know that one of the biggest and most effective ways that we can reduce new infections, whether we're talking about HIV, syphilis, or other STIs, is to identify people who are currently infected and to rapidly address their health needs by linking them to care and treatment. So as an example of that, we have routine opt-out testing, which we know is an effective structural intervention that reduces the need for folks to take action. Meaning that when folks are routinely tested in medical settings, whether we're talking about emergency departments or clinics or federally qualified health centers, they don't have to take it upon themselves to specifically come out and ask for an HIV test. It's something that just happens automatically when they seek medical services. So routine opt-out testing as a structural intervention automates this process, which makes it easier for folks who may be HIV or STI positive to be identified and then rapidly linked to care and prevention services, and really make sure that their health needs are met and addressed as soon as possible. So before I go deeper into this presentation, I just kind of wanted to briefly talk about the theory of planned behavior, right? So we know that most theories of behavior change require something to happen before the actual behavior change happens itself. For example, if we feel like we have no control over smoking, then we probably won't change it. But every behavioral change theory identifies certain steps and stages and actions that precede the actual behavior. So many structural interventions are intended to decrease or even eliminate those contemplation phases and bring the decision and action stage to the front and center. So that folks aren't having to actually think about making this change, or the example of they're not having to actually go and ask for an HIV test. It's just something that is routinized and becomes part of it. And so just to provide a personal example, one of the things that I have tried to be better about is drinking water throughout the day. I've always been very bad about that, and I'd get thirsty, and then I would drink all of these diet sodas and juice and Gatorade and things like that. And I just started thinking like, well, the amounts of caffeine and sugar that I'm probably taking in my body is not great for me. And so when I realized that I could increase my water intake by using water flavorings like Neo or Crystal Light, it really prompted me to increase my water intake throughout the day. And so, I've now changed that behavior. That's something that, I have improved. Okay, so back to talking about reducing new infections by identifying current infections. I wanted to continue to talk a little bit more about the benefits of Root. So in addition to reducing the need for folks to take action themselves, Root also reduces stigma. And I've seen in the chat already today, folks have called that out, that we really need to reduce stigma. And that is a component that has to be part of our structural interventions. Root eliminates stigma or reduces stigma because it eliminates the need for folks to seek out a special service or request for an HIV or an STI test, which can be scary or, possibly leave somebody feeling, a little exposed. Stigma has been very prevalent in the realm of HIV historically, and there were really justifiable reasons to treat HIV exceptionally. People could be denied for or lose their health insurance, their employment, their housing, and their family and friends. And so when we normalize HIV screening and blend HIV services with other client needs, that reduces stigma, and it's really critical to lowering new HIV infections. So when HIV screening is treated similar to other health screenings, like whether we're talking about monitoring for diabetes, cholesterol, or blood pressure, HIV screening becomes normalized. And bringing sexual health screening into the norm of folks' overall health screening will increase the number of people who know their HIV status. So as the Ending the Epidemic counties begin to offer street medicine programs, they're expanding the healthcare services offered not only to decrease stigma, but to increase treating the whole person and their needs. As a syndemic, we know that we need to offer HIV, STI, and HCV testing together. And by doing that, that is a structural intervention in itself. All right. Now, as this presentation was being developed, the CDC presentation on status neutral approaches presented this slide, which shows that among the 59 Ending the Epidemic plans that were submitted, more than 75% of these jurisdictions in the red cited stigma as a critical issue that has to be addressed. And as we know, status neutral approaches offer responses to all different types of people, whether they're people living with HIV, people of unknown status, or people who may be negative. And these approaches also blend care and prevention efforts and can effectively create a one-stop shop where anyone can come in and be linked in wherever they fit in. And so any door is a viable door in status neutral approaches. And so all of your creativity in developing structural approaches to decrease stigma will increase your effectiveness at reducing new HIV infections. And when we can talk to most folks out there about U equals U and that they understand that we're talking about and what it means to be undetectable, then we will have an idea that some stigma is being lessened as folks know more. We also know that Root creates a valuable opportunity to identify people that are unaware of their HIV positive status. It also has the potential to facilitate a situation where a medical provider can speak with folks who may have avoided seeking an HIV test out in the past because of fear or denial or possibly medical mistrust. It creates that opportunity. It's not uncommon for a cisgender woman to be surprised when she's diagnosed with HIV she may not have perceived herself to be at risk, or may not have had an identified risk according to our instructions for safer sex approaches. But Root removes the need for someone to identify as being quote unquote at risk before they seek an actual HIV test. So, wouldn't it be fantastic if women who are getting routine mammograms would also be offered an HIV test and at the same time? This is just another example of a potential structural intervention. And also another intervention that you may want to consider, or consider inviting those living with HIV to bring a friend from their social circle to test. This has been demonstrated to yield a higher positivity rate than found in routine testing programs. So, it really kind of brings in that idea of using a social network testing, as we know, has a higher rate of folks who test positive and can be linked to services as quickly as possible. All right. So again, just to kind of reiterate these points, the merits of Root are clear, and structural interventions such as Root reduce the need for an individual to take action themselves. They reduce stigma and have the potential to identify people who may be unaware of their status without fear and denial. So I would challenge you all, next time you are at a medical visit, to ask your provider if they routinely screen for HIV, and if not, ask why. I've asked that question myself, and I've usually received a range of answers, which could be anywhere from they don't know why, or it takes too much time, or it's just not something that they do. So it's always interesting to hear the perspective. So but these are some things and some easy ways that we can alter policies and procedures, and in itself, that is a structural intervention. So at this time, if folks, I'd like to invite folks to use the chat and share what policies and procedures have you changed or could you change to increase what we've been.
Hey, I'm just in a webinar. Let me pause 1 second.
Please mute yourselves. Thank you. So please use the chat feature and talk about or mention what sort of procedures have you changed or could you change to increase the accessibility, acceptability, and availability of your services. Think about the changes you've made during the pandemic, because I know that folks have been really agile and kind of like switching some of their protocols and procedures during the pandemic to still be able to meet the needs of clients. So if you could just add some examples into the chat, I'm going to go on to talk about some of the examples that we have here on the screen. And the first one is to offer office hours outside of the normal range. Is that something that you're able to do? We saw a lot of this kind of adaptability during the pandemic with community-based organizations and testing organizations and clinics expanding their hours or taking appointments outside of normal hours to increase access to folks. You could change your hiring practices to bring folks with lived experience into your staffing and your workforce. And we know that it means so much to have staff that represent the communities and populations that we serve. Be intentional about the atmosphere that you create within your clinic. Create self and welcoming spaces with your clients, right down to the folks who lead the intake process. Just some of the things you could do, you could use music or imagery such as posters and palm cards and things like that in your clinic or office that really speak to your clients and make them feel welcome, comfortable, and represented. You can locate your services in venues that are often accessed by your clients and priority populations. Another example of a structural intervention is you can change your policies and procedures to do comprehensive blood panels, which test for multiple things, and then these screenings would be done more routinely. I just want to look at the chat. People say telehealth, yes, definitely. Flexibility with office hours. Meet the client where they're at with mobile testing. Yes, and if you're mobile testing for HIV, can you also incorporate chlamydia and gonorrhea testing? You know, we've seen some folks do that with their mobile testing. Home test kits, yes, definitely, which I will talk a little bit more about. Health promotion materials focusing on culture as a tool for better health outcomes. Culture is medicine. Yes, thank you for that.
And translation of documents and information, really important.
Yes, definitely. Translation. Okay. All right, so we've talked about today the value of including folks that are part of the priority populations in the development of your structural interventions. Community engagement is a requirement that is in both the National HIV Strategy as well as the Ending the Epidemics initiative. And, you know, we've been bringing community voice into community planning groups and councils and advisory committees for years, and also hopefully in monitoring and evaluation. So we really need to continue and strengthen that method of community voice and community input. You know, we also recognize the importance of working with community leaders and gatekeepers, not just to access populations, but to guide us in what is needed to support reducing new infections among those communities. We really want to see people from the priority populations taking part and collaborating in developing and delivering effective services. Again, this goes out to, or back to the idea of nothing about us without us and for us by us. When you create a forum of folks from priority populations to participate and collaborate, you're achieving an effective structural intervention. And this could also take the form of focus groups or ongoing advisory committees. And community input is so important here. Just some questions for food for thought, and please feel free if you're inspired to add anything to the chat. Let's really kind of share some ideas and best practices with one another here. Does your agency have a client suggestion box or other mechanism for feedback? And that is like one of the easiest ways to kind of get input and feedback from folks that are accessing services in real time. When was the last time you surveyed your clients so that they can share their impressions and experiences with your services? And what are some ways you learn about their priority needs? What policies and procedures could be adjusted to make community planning more accessible to your priority populations? I do want to caution that we need to be prepared to respond when we ask people what they need. So what are the limits of our abilities and the services that we can provide? And when we cannot fill a need, do we have the means to link people to a source that is able to respond to that need? So we know that having a referral list or building a rapport with various social service providers that offer other services that your clients need, that's creating a structural intervention when you have a referral network. How you refer can be another structural intervention in itself, and telling someone about a resource is not really as effective as doing a warm handoff procedure directly to that resource. So this quote on the slide comes from Orange County, where they are developing some work specifically for trans individuals and are using focus groups and a survey with a goal of meeting the need of how do we engage these folks in HIV testing. You cannot focus on HIV needs without addressing the needs of the whole person. You need financial stability, accommodation, etc. You need mental health assistance, even if it is in a group. It is a good start. So the community engagement input used to develop Orange County's Ending the Epidemic plan identified the transgender community as a priority population. And working with an agency run for and by transgender women, a survey and focus groups gave the county and the organization insight on what was needed by the women who they plan to support. The engagement created a series of recommendations that can guide the development of effective services to reduce the number of new infections among Orange County transgender residents. And it also provided an opportunity for transgender women to come together and share their experiences with one another. And that is also having that kind of group setting as well for sharing experiences is very important as well. All right, so a little bit more about the value of community engagement. Community engagement, we know, benefits everybody all around, and that includes the funder, the contractor, and the folks who are being served by the interventions. It enhances our effectiveness at accurately and successfully providing services to the community. And why? Because hearing from the people to be served from the formative phase forward increases the likely effectiveness of the program. So that means that we should really be avoiding bringing in folks in as an afterthought, and meaningful side-by-side collaboration and engagement is so important here. The want and need of folks representing community voices may require you to have to address areas that maybe you didn't plan to address, or make changes in policies and procedures, and bringing additional resources into the program. And community engagement in itself builds community and strengthens overall work toward decreasing the number of new infections. All right, so let's talk about addressing the needs of the whole person. So if you identify a need for someone and you don't have that service, you should have a warm handoff or a repertoire in place or a catalog of services for referrals to link people to necessary services, even if we don't provide those services ourselves. It's really important to acknowledge that we have so many silos and policies that create silos or could prevent those silos from being dismantled in the field of HIV. And there is a need to de-silo even further as we start integrating with identifying, treating STIs in the field of sexual health. You know, we know that most medical providers don't necessarily employ outreach workers, but outreach workers are a very highly skilled group of folks at reaching out to people and assisting them and linking them to services. However, medical institutions and HIPAA rules have been a barrier to collaborative relationships, unless we advocate strongly for policy changes and increase collaborative relationships. Grant requirements, for example, such as MOUs or memorandums of understanding or memorandums of agreement, are intended to increase these types of collaborations, and requiring research institutions to partner with community-based organizations is another example of a structural intervention that is intended to ensure and encourage collaboration. So let's look at a few different hypothetical situations here and think about how can or how would you respond to these situations. The first one on the screen is that, say your client has a partner or partners of different HIV status. Are you offering status neutral approaches? Try to de-silo when possible. We know that HRSA funding care is for people who are positive, and CDC is for both positive and negative folks. So if we can integrate so that case management isn't just for positive folks and that people with both statuses can be served at the same location, that would be fantastic, and would allow for more innovative services. Can your ADAP enrollment workers also enroll people in PrEP app? So if there are people who can do both ADAP enrollment and PrEP app enrollment, that is a status neutral approach and affords the couple to be served at the same time by the same person. Do you offer time for your client and their partners together to discuss questions and concerns with you? Do you develop consent forms that allow for clients and partners to be seen together? Or, are you making sure to have referrals ready for common needs and support? Get on a first name basis with the folks that you're referring, and build collaborative relationships. Just a couple other things that are food for thought. Does your Ryan White staff routinely meet with your prevention staff? What are you doing or could you do to bring status neutral services to those who are living with HIV and those who would benefit from prevention services? All right, the next example, this scenario, an individual is diagnosed with an STI and has 3 sexual partners. Are you able to assist them to speak with their partners? If not, there are some resources here on the screen. There is STD Check, which allows for anonymous notification, tellyourpartner.org, betterknow.org, which also allows for notification. And can you facilitate the partners being screened and treated? So, someone brought up self-testing a few minutes ago. That is an option with our Take Me Home self-collection for HIV, STI, and HCV screening. I'm going to talk a little bit more about that in a section, or in the next section. We have these software programs that will really meant to assist folks in notifying their partners. And so let's make sure to utilize those. This is a great example of a structural intervention for folks to receive testing for HIV and STIs. And it has become so important with the pandemic, especially, during the last 2 years. This option provides your clients access to screening in the privacy of their own homes. It's currently supported by the 8 California Ending the Epidemic jurisdictions, and we hope to extend the oral self-test HIV screening statewide. Some eligibility criteria varies by LHJ, but one of the really great things about this option here is so, for example, what if a client is frightened or nervous or concerned about a kit being sent to their home? You could offer to have it sent to you and then have the client come in and collect it. So that's a simple structural intervention that removes a barrier that can increase acceptability and accessibility of a test kit. This example is a great example of a structural intervention. So say a person is chatting or hooking up with others on an app like Grindr or Scruff or Adam for Adam, and there's a banner that prompts folks to take advantage of a free HIV test kit without much thought, then the individual can have access to a test fairly easily. Take Me Home also includes options for dry blood spot testing for HIV, syphilis, and hepatitis C, and also swabs for gonorrhea and chlamydia as well. We are currently in the development of a contract to expand, as I mentioned before, self-testing to HIV in all counties in California. And the last scenario here, if your client doesn't have enough gas to attend multiple appointments scheduled on different days. We know that transportation can be a huge barrier, especially in some counties where, it's a lot of miles to the nearest HIV services. And, in speaking for California, like we have counties that are huge, and travel can definitely be a barrier for folks. So what are some things that we can do to address this? We know that COVID has had some beneficial consequences. So for example, telehealth visits have become a necessary option for clients. And it seems like this option is here to stay. Same-day appointments are extremely beneficial for rapid linkage to treatment and prevention, like PrEP. We know that sometimes policies can get in the way of providing effective services. So we recommend that you review your policies for situations where maybe a client is late or missing appointments. Are your policies taking into consideration the client's transportation resources or lack of resources? So better assessment of a client's transportation resources and increasing our support for transportation can greatly influence our effectiveness when we're trying to reach the goal of reducing new infections. If you're able to provide transportation reimbursement prior to the visits, can you provide Uber or Lyft cards for folks prior to them coming in for their appointment? As I mentioned earlier, referrals are so important, and consider referring clients to services that are closer to their home if it makes more sense to them. If you're aware that these needs can be met in an easier way for that person. There are times that referring clients to other agencies is in their best interest. So like if we act in their best interest and have referrals set up, sometimes that means referring clients to other organizations. And the more collaborative relationships you build, the greater number of resources you will have to offer to your clients. And so it's really kind of about building that toolkit and repertoire with other providers in your area. Just to summarize, let's pay attention to the structural interventions that are already in place, and how can you increase or expand those? How can you make those better? Assess your services and think about what can you do to make them more the 3 A's. So accessible, acceptable, and available to all of your clients, and use technology when it can help to achieve these 3 A's. Collaborate rather than duplicate. We can't be all things to all people, and having those networks in place for referrals is super important. And lastly, let your clients guide you. Engage the community, and you will learn how to more effectively reach and serve your populations, which will help in turn reduce new infections.